We're going to continue our discussion of pressure ulcer prevention, and in this session we're going to focus on the role of support surfaces in providing protection against pressure ulcer development. Forgot my mouse, sorry. So I wanted to begin by talking about the specific risk factors that are addressed by support surfaces and impacted by support surfaces. There are three: immobility, shear and friction, and moisture. By far the most important, of course, is immobility, one of the major risk factors for pressure ulcer development. Now, if you have a patient on a fairly rigid surface, a non-conformable surface like a standard bed or a standard chair, that patient's weight is supported primarily by their bony prominences. And what happens is you get peak pressures over those bony prominences. That leads to rapid collapse of the capillary beds in that area because the blood is shunted, diverted to surrounding vessels. When you get almost total collapse of the capillary beds over the bony prominences, you get fairly rapid development of tissue ischemia. And in that case, to protect the patient against pressure ulcer development, you have to reposition them very frequently. With therapeutic support surfaces, they've replaced that fairly non-conformable top surface with a very conformable surface. And as a result, when you manage a patient on a therapeutic support surface, that patient sinks into the surface, it contours to their body contours. The weight is distributed pretty evenly. And when you evenly distribute the weight, you significantly reduce peak pressures. When you reduce peak pressures and when the pressures are spread evenly across a broad surface, then the vascular system can protect itself because it's a closed system. There's nowhere for the blood to go. So in that case, the blood essentially keeps the vessels open. So putting the patient on a conformable surface goes a very long way toward reducing the risk of tissue ischemia and allowing you to protect that patient with less frequent repositioning. So a patient who might need hourly repositioning on a non-conformable surface can be repositioned every 2 to 4 hours on a conformable surface. So that's the most important risk factor addressed by therapeutic support surfaces. But there are two others. The second one is shear and friction. When we talked about the pathology of pressure ulcer development, we said that friction can cause superficial damage just with the patient scrubbing around in bed. We also said that that friction contributes to shear force because frictional forces tend to hold you in place while gravity tends to pull you down. When you have a patient on a standard surface, the skin tends to stick to the sheets. Gravity pulls you down, the fat gets sheared in between, and the vessels passing through the fat layer get kinked or torn, resulting in major tissue damage. With therapeutic support surfaces, they can replace that fairly stiff and sticky top layer with a very slick top layer, one that's made of Gore-Tex or similar material. When you replace the top layer with that very slick layer, then the patient slides easily without any drag, without any friction. All tissue layers move together, and you go a long way toward eliminating damage from friction and shear. The third risk factor that is addressed by some, though not all, support surfaces is moisture. We talked a lot about the negative impact of overhydration on the skin. We talked about the fact that when the skin's overhydrated, the cells lose tensile strength. That when your skin is overhydrated, you tend to drag against the surface instead of gliding against the surface. So we talked about how important it is to keep the skin surface dry as opposed to wet. Now they talk about microclimate control. That's a relatively new term, but you'll read about it, you'll hear that term when you go to conference, when you read your journal. So when they talk about microclimate control, that's what they're talking about. They're talking about controlling moisture, keeping the skin from becoming overhydrated, and they're also talking about controlling temperature. So keeping the skin cool and dry so that it's not hypermetabolic and so that it's not dragging against the bed surface. Some of your support surfaces now incorporate a pump and little perforations in the surface of the mattress. Those devices reduce skin temperature and reduce moisture by blowing air through the little perforations in the mattress. So when the pump is on, it's circulating air through the mattress, and air is blowing up through those little micro perforations against the skin and helping to control both moisture and heat. So three factors, three very important factors that are addressed by therapeutic support surfaces. The negative effects of immobility by providing even pressure distribution, reducing peak pressures. The impact of friction and shear by providing a very slick surface so that the patient can slide without sustaining tissue trauma. And finally, control of moisture and heat so that you keep the skin cool and dry and you reduce the potential for drag force that is a significant factor in skin breakdown. Now, before we get into specific types of support surfaces, I want to go over just some general guidelines and also some common misconceptions that you want to address when you're talking to your staff and teaching your staff. First of all, in some settings, overlays are still used. Now, you're seeing that less commonly, but you might be in a setting where overlays are still used, and if you are using overlays in your setting, you want to make sure they're used correctly. Now, I want you to imagine that this is the overlay. This is the mattress. Here's my patient. I want to make sure that my overlay is providing enough support and that the patient is not bottoming out. What we mean by bottoming out is that their bony prominences are actually at the bottom of the overlay and sitting right above the mattress. The way I check for this is I slide my hand between the overlay and the mattress, underneath the patient's bony prominences. I should not be able to feel that patient's bony prominences. If I can, then clearly the patient is not adequately supported by that overlay. He or she is bottoming out. Their weight is actually going right down to the mattress, and I have to replace that overlay. I have to put them on a different device because it's not giving them enough protection. So anytime you see a patient on an overlay, you want to make sure that you check that overlay for bottoming out. The second thing, of course, is a key element of any prevention program, and that is monitor the patient's skin status. Make sure that what you're doing is working. So maybe I have a patient, and my initial assessment was that I could manage this patient very effectively on our existing pressure redistribution mattress that might have a low shear, low friction cover, but does not have airflow. But 1 week into the patient's admission, the staff reports to me that the patient's developed a stage 1 over the sacrococcygeal area. And when I go and I evaluate the patient, the staff is correct. The patient does have a stage 1 ulcer. Furthermore, I note that the patient has had frequent episodes of fever and diaphoresis and increasing incontinence of liquid stool. So now I have to modify my care plan. I'm probably going to put that patient on a higher level surface. I'm going to pick one with airflow. And I'm definitely going to use either a fecal pouch or a bowel management system to control the fecal incontinence. So monitoring and moving the patient up if the device you're working is not giving them enough protection. The third thing is make sure that everyone on your staff understands that support surfaces do not protect heels. Very hard to protect heels. Heels are actually the second most common site for pressure ulcer development. And in recent years, we've had increasing numbers of patients developing heel ulcers. Pretty easy to understand. When you palpate the heel, you realize that the calcaneus is a very large bone and that there's practically no soft tissue overlying that bone. Even if you have a patient who's overweight or obese, when you palpate their heel, there's not much soft tissue over the heel. We just don't make fat over the heel. So that means that there's no way to redistribute the weight. Now, add to that the fact that when you're in the supine position, about 20% of your body weight is supported by each heel. So you can't effectively redistribute the pressure. There's a significant amount of weight being supported by a very small surface area, meaning you get very high peak pressures, very rapid development of tissue ischemia. And you've seen that. You've seen patients who develop these foggy heels. Well, what about if you have that patient on an air mattress? Will that air mattress protect the heels? No, there's just not enough surface to redistribute the weight. So the only way to effectively protect heels is to get them off the bed. Whether you use a pillow, whether you use a heel elevation device, you can't just use heel bows or booties because they don't get the heel off the bed. They might reduce friction, they do not reduce pressure. So you have to actually get the heel off the bed. There are some support surfaces where the manufacturer has built in a pressure relief system for the heel, and that allows the heel to float. Bottom line, your staff has to know, when you have an at-risk patient, heels should be floating. If they have a feature on the bed that keeps the heels floating, fine. Otherwise, they have to use pillows or a device to get the heels off the bed. They don't have to be very far off the bed, just a millimeter, but you want them off the bed. And then finally, a very common misconception among nurses is that if the patient's on a high-level support surface, like an air bed, they don't have to be repositioned. And you want your staff to know all patients get repositioned routinely unless there is a medical contraindication or the patient refuses to turn even after you've educated them and tried to convince them of the importance. Even if you're on a high-level surface, it's not going to totally protect your tissues. Plus, we should be turning patients for pulmonary benefits, for renal benefits, all of those things. So you want everyone on your staff to know all patients get turned unless there's a medical reason or the patient refuses. In that case, the staff needs to know to write one-line documentation about what happened. For example, 10 p.m. to 6 a.m. unable to reposition due to hemodynamic instability. Okay, the next thing I wanted to talk about is the types of support surfaces available to us. Of course, you know there are many, many mattresses, overlays, beds, chair cushions. It can be overwhelming. But we want to bring it down to size. We want you to be able to look at support surfaces, know what to ask, know what each feature means, and know how to apply that appropriately, both in your decision trees and in selecting a device for an individual patient. We want you to be able to sit down with your vendor and know which products you need in your agency and when to use them. So we're going to go through 3 different ways that you can classify support surfaces. You can classify them based on therapeutic effects. That's by far the most important classification. You can classify them by their relationship to the existing mattress and bed frame. Or you can classify them based on the material used to provide pressure redistribution. For example, foam versus air. We're going to spend most of our time talking about classification based on therapeutic effects because that's what you're after. That's why you're using the support surface. And we will talk about, well, when would you want an overlay and when would you want a mattress? and when might you use a bed, and what's the difference between foam and air. But it all comes back to what does it do for your patient from a therapeutic perspective. So let's look at the three major therapeutic benefits. We've already mentioned them once, and now we want to look at it from the perspective of how can you tell what you're getting, or what are the factors that impact on what you're getting, because it's pretty straightforward actually. So let's talk first about that pressure redistribution. Almost all of the devices on the market are designed to provide more even pressure distribution by giving you a more conformable surface. We've already said that. Now, you can look at all the devices on the market and you can classify them as providing intermediate level pressure redistribution or high level pressure redistribution. And it goes back to the material used to provide pressure redistribution. The two most common materials are foam and air. Now, foam is generally considered to provide mid-level, intermediate level pressure redistribution. Foam can be designed to be very conformable so that when you rest on that surface, it tends to conform to your body surface and to more evenly distribute the pressure. But foam is a solid, and there's no way it is ever going to be as conformable as air. Air is totally conformable. And if you have a mattress that is air-filled, and if the surface of the mattress is extremely conformable, then you will literally sink into the mattress. It will envelop you, and you will get extremely even distribution of the pressure. So in general, your air support mattresses are going to give you high level pressure redistribution, and your therapeutic level foam mattresses are in general going to give you intermediate level pressure redistribution. Still makes a huge difference. I don't want to make it sound like, well, your foam mattresses don't do a good job, because they do. And most of your patients can be effectively managed on those devices. I just want you to think about the difference between foam and air. I want you to think about the reason that we typically put extremely high-risk patients on an air support mattress. The second thing is shear and friction control. And you can usually look at a device to determine if it's going to provide shear and friction control. You just look at the cover. Is it a Gore-Tex type cover? Is it a very slick? Now, the companies have actually been involved in an initiative to quantify the level of shear and friction reduction, to come up with measures that they could carry out, that there would be an industry standard, and that they could use standardized testing and then give you standardized results. We don't really have that on the market yet. It probably is coming. But in the meantime, you can literally look and feel the surface of the mattress, and you can also ask the vendor, does this device provide shear and friction reduction, and what data do you have? And then the third thing, we've said that some of your devices provide microclimate control and others do not. So how do you know if the device provides microclimate control? In general, you need two things. You need a pump to circulate the air through the device, and you need microperforations in the surface. So you've got to talk to the vendor. Does this surface provide microperforations? What's the volume of airflow? Do you have any data that tells me about the ability of this support surface to keep skin cool and dry? Now, I can tell you that some of your surfaces do not have a pump. They work by creating a very reactive surface, so that as the patient shifts, air shifts from one compartment to another. And they may have different methods for trying to provide microclimate control. If you don't see a pump, you've got to ask the vendor, does this surface provide any microclimate control, and if so, how? And where's your data? So those are the things you're always looking for. And you want to match your surface to the patient. So let's go back to our earlier example. A lot of your patients will come in, they don't have major problems with diaphoresis or incontinence. They may not have major problems with sliding down in bed. Maybe the primary thing they need is pressure redistribution. And your existing mattress provides mid-level pressure redistribution, so you put them on that device. But if their condition deteriorates and they require head of bed elevation because of tube feedings, then you've got to look at that device and you've got to think, does this device have shear and friction control? If not, I need to upgrade this patient to a device that provides shear and friction control. If a patient has major problems with moisture, you've got to upgrade them to a device that provides moisture control. Now, big picture categories. We divide mattresses into mid-level and high-level surfaces. So we'll say, well, I'm going to manage this patient on a mid-level surface, or this patient's very, very high risk. I'm going to put this patient on a high-level surface. What do we mean by that? If we say we're going to manage this patient, or we believe this patient can be managed on a mid-level surface, what are the characteristics of a mid-level or intermediate level surface? And you see here on the slide, you're going to get mid-level pressure redistribution. So that's what you get from those mattresses that are constructed from foam, foam and air, foam and gel. They usually have a surface that provides conformability, and the underlying foam provides conformability. So you're going to get pressure redistribution. You're going to get a marked reduction in peak pressures. That's going to allow you to reposition the patient typically every 2 to 4 hours and give that patient good protection. A lot of your mid-level devices also have a cover that provides shear and friction control. But your mid-level devices don't come with pumps in general and don't provide microclimate control. So all of your mid-level devices provide mid-level pressure redistribution, and many provide shear and friction control. But most do not provide microclimate control. What are the characteristics of a high-level surface? A high-level surface is going to be an air support surface, and air gives you maximum conformability, so you're going to have an air-filled mattress with a very conformable surface so that the patient literally is enveloped by the device. You are going to have a cover that is slick that provides shear and friction control. You are going to have a pump and the micro perforations to provide microclimate control. So you see your high-level device gives you everything. And that's what you're going to need for your extremely high-risk patient who is immobile, exposed to shear and friction, diaphoretic. But many patients can be managed on your mid-level devices. So your goal is to help your staff know when to move a patient up to a high-level device and when it's appropriate to keep the patient on that mid-level device. And you're going to set up decision trees to help them, and then you're going to back them up. Now, in making decisions about mid-level devices and high-level devices, there's three things that you want to think about. You want to think, how many turning surfaces does the patient have that are intact? So if a patient comes in and has no breakdown, and there's no contraindications to turning them on their right, their left, their back, then they have 3 intact surfaces. If I come in and I have breakdown on the sacrococcygeal area, maybe I have a deep tissue injury on the sacrococcygeal area, but my right trochanter is fine, my left trochanter is fine, then I have 2 intact surfaces. That's an important consideration. We'll go over that in just a minute. The second thing is the level of risk. If your patient's moderate risk, then most of the time you can manage them on the mid-level surface. But if a patient's extremely high risk, it's very likely that they'll have multiple risk factors that you have to address. Your very high-risk patients are very likely to need everything: high-level pressure distribution, shear and friction control, and moisture management. Now again, you've got to use your critical thinking skills and your clinical judgment. Maybe I have a patient who's moderate risk when I look at the total score, but is diaphoretic and has very thin skin. I'm going to manage that patient on a high-level device because they need moisture management. So these are general guidelines. You always use your judgment. And then the third thing you think about is what we were just saying. You've got to factor in, does this particular patient need airflow? Does this patient need shear and friction reduction? So let's look at how we make this work clinically. Let's say you have a patient who comes in, they have no breakdown, they're moderate risk, meaning that their brain score is somewhere between 12 and 18. Most of the time, you could manage that patient on a mid-level surface. And if you look at the slide on top, what I'm showing you is one of the redesigned hospital mattresses that are designed to provide mid-level pressure redistribution and maybe some degree of shear and friction control, because you can see this is constructed from foam and it's going to have a conformable surface. So you're always going to get pressure redistribution. If that conformable surface is also slick, like Vortex, you'll also get shear and friction management. There's no pump, so you're not going to get microclimate control. If your patient needs that, it would change your decision, but otherwise you could manage patients who have no breakdown and they're at moderate risk. You can manage them on that mid-level device. What if I have a patient who has no breakdown but is high risk? So now their brain score is less than 12, maybe it's less than 10. Most of the time you would upgrade that patient to a higher level surface for the reasons we've already said. Most of the time when you look at their subscale scores, not only are they bedfast, immobile, possibly malnourished, but many times moisture is an issue and almost always shear and friction is an issue. In that case, you want them to have the highest level surface available, and you want to be addressing everything. You want to provide high level pressure redistribution, you want to provide shear and friction control, and you want to provide microclimate control. Okay, now let's go to our second thing. What if we have a patient who has breakdown on one surface and they're at moderate risk? Well, we mentioned this already. One surface, moderate risk, you still have two surfaces that you can use for repositioning that patient, and you can keep them off of that one involved surface. So if I have sacrococcygeal breakdown, but you can turn me right to left and keep me off of the coccyx. And I'm at moderate risk and I don't have any other particular needs, you can manage me on a mid-level surface. I want to point out in parentheses, if you can keep the patient off the area of breakdown. Why does that matter? It matters because if you have an area of breakdown, then that tissue is in the healing process. And healing is a metabolically intense process requiring a lot of oxygen. It takes a lot more blood flow and oxygen to heal a wound than it takes to maintain intact tissue. So if I have intact tissue on my right trochanter, intact on my left, it's fine to position me on my right trochanter for 2 to 4 hours. Yes, you're going to get some degree of soft tissue compression, some degree of vessel compression, some reduction in blood flow, but I have healthy tissue that's going to be able to tolerate that. It's going to have, that tissue is going to have low oxygen demands. If I had a wound on the trochanter, then every time you turn me onto that surface and you reduce blood flow to some extent, then you're going to compromise the healing process for the period of time that I'm on that I'm turned to the right. So how does that translate into selection of a support surface? If you're forced to position me on an area of breakdown, you want to make sure that you're providing me with the highest level of pressure redistribution possible, because you want to minimize the interference to blood flow, minimize the interference to healing. So let's look at it both ways. I'm your patient. Let's say I'm moderate weight. I'm totally immobile. I have breakdown on the coccyx, but when you turn me to my right, you can get me off of the sacrococcygeal area. You can see that that area is totally offloaded. When you put a wedge behind me, I stay on my right side. I don't go back to the coccyx. You come back, you turn me to my left, you put a wedge in place, I stay on my left. I'm not diaphoretic. Could you manage me with a mid-level surface, mid-level pressure redistribution, possibly shear friction control? Yes, because you can keep me totally off my coccyx. You can maintain maximum blood flow to the sacrococcygeal area. Turn me right, turn me left, turn me right, turn me left. Absolutely appropriate. Now, let's change one thing about that. Let's say I'm your patient. I have sacrococcygeal breakdown. I am obese. Maybe I'm morbidly obese. And so you come in and you turn me to my right. You're not sure you get me totally off the sacrococcygeal area. You do your best and you wedge me. But when you come back to turn me, you see that I've shifted back. My weight's caused me to shift back. And now I'm definitely lying partially on the sacrococcygeal area. Turn me to my left, the same thing. You're not sure you get me totally off that area, and when you come back, I've shifted back part way. You're going to move me up to a high level surface, because the reality is most of the time I'm at least partially on that area of breakdown. You're trying to get that area to heal. You know it's a metabolically intense process. You know you need to maximize perfusion. So you're going to put me on the highest level surface possible. I hope that makes sense. If it doesn't, give one of us a call and we'll walk you through it, because it's a very important concept in making sure you're using your support surfaces correctly. If you have breakdown on more than one surface, so let me give you another example. Let's say you have a patient and the patient has contractures. And so the patient's been managed at home by their family, and they've been turned from the right to the left, from the right to the left, and they have breakdown on their right trochanter and their left trochanter. And the reality is that you can't effectively position them in the supine position because of the contractures. Even if you could position them in the supine position, you couldn't leave them there, because then you would get breakdown over the sacrococcygeal area. So the reality is you're going to have to position that patient on areas of breakdown. And what do we say? If you have to position me on areas of breakdown, you want to minimize the interference to blood flow so that you can maximize healing. So you're going to put me on the highest level surface you have, so that you get very high level pressure redistribution. So looking at it from another way, coming at it from another way, you're going to use high level, which is your air support surface, low shear, low friction cover, a source of airflow to maintain microclimate control, so your pump and your microperforations. Definitely for patients who cannot be turned, because you have to minimize any interference to blood flow. You've got to give them the absolute maximum in pressure redistribution. Any patient with breakdown on more than one surface, or if they have breakdown on one surface and you can't keep them off of that surface. We talked about that in detail. Patients who are very high risk, because usually they require maximum pressure redistribution and they usually have multiple risk factors that need to be addressed. Also, I think about a high level surface for patients in severe pain, because I'd like to dial down the turning frequency. and I want to make sure they're literally floating on the surface. So I usually use a high-level surface for patients in severe pain. And if I have a patient who needs moisture management or shear control, definitely they're going to go on a high-level surface. But you have lots of patients who can be managed on that mid-level device. And what is a mid-level device? It's an air or a foam overlay, or most commonly it's a pressure-reducing mattress. And a pressure-reducing mattress is typically made of foam with or without other constituents. So who can be managed effectively on your mid-level surface? Your patient who is moderate risk, either has no breakdown or they have breakdown on one surface that can be protected effectively. You can offload that surface effectively and continuously. And there's no need for moisture control. This is where we really want you to focus your attention. What do we mean by mid-level? What do we mean by high level? Which patient needs high level? Which patient can be managed with mid-level? So again, if it's not making sense, please do call us. Now I wanted to just mention some other surfaces that are out there. This is not where we want you to put your attention right now, but we wanted to mention these and how they're used and when they're used. Alternating pressure. Now, for many years, alternating pressure pads were the mainstay in therapeutic support surfaces. Most of them were overlays. You have some that are alternating air mattresses, but they have a combination. They actually provide a combination of air support and conformability with alternating air. So right now, I'm talking primarily about your overlays. Alternating air overlays are hooked to a pump, and they have a series typically of longitudinal air channels. And at any point, half the channels are inflated and half the channels are deflated. So if channels 1, 3, 5, 7, 9, and 11 are inflated, 2, 4, 6, 8, 10, and 12 are deflated. And then when it cycles on, or the cycle shifts, 1, 3, 5, 7, 9, 11 are inflated or deflated, or whichever I said. Anyway, it shifts. Sorry. So you can see that that works by a totally different mechanism. Now you're not focused on even distribution and avoiding peak pressures. Instead, what you're doing is you're constantly changing the pressure points. Now, there have been some concerns as to how effective alternating air pads are. First of all, they're usually overlays, and certainly with heavier patients, they may not get enough support. When only half of the air channels are inflated, it might not adequately elevate the patient, so they might be bottoming out. Back to the caveat, always check your overlays to make sure they're not bottoming out. Also, we're not clear as to the optimal size of the air channels to effectively change pressure points. The majority of the support surfaces on the market today work on the principle of even distribution as opposed to changing pressure points. But I did want to mention alternating air because you may encounter that. And you know what? It might be working very well. I would say if you have those devices and you're using them, then monitor your outcomes. If you see any deterioration, think about moving the patient up to another type of device. Alternating air doesn't typically provide low shear, low friction, and moisture control. But again, new devices are coming on the market all the time. A lot of companies will combine therapies within one product. So I just want you to be aware of what they mean when they talk about alternating air. And I specifically want you to be aware that if it's an overlay, you've always got to check to be sure that that patient's not bottoming out. Continuous lateral rotation therapy, these are devices that are programmed. It's actually it's always connected to a pump. And what it does is it constantly changes the angle for the patient, so it's literally continuous lateral rotation. It is not for skin care, it's for pulmonary care. And when you watch the patient on a continuous lateral rotation mattress, you'll see that it's primarily their upper body that turns, not the trunk. Upper body lung fields. So you might be doing a very good job of protecting the lung fields, but their trunk, the sacrococcygeal area, is not being affected. They're not turning the patient at the level of the trunk. So the bottom line is that the patient's on continuous lateral rotation therapy, because that patient has a major pulmonary issue that takes priority. But you need to add routine positioning to offload the sacrococcygeal area unless there's some contraindication to doing so. And then the last thing I wanted to mention, and this is a very important consideration for most of you, because I'm thinking most of you are caring for bariatric patients, whatever your care setting. So you need to be very clear in talking with your vendors, looking at each product line. What is the weight limit for this mattress? Because you want to make sure that you're managing patients on appropriate mattresses. Also, you have to consider girth, because if you have a patient who's relatively short and whose weight is concentrated in the trunk, then maybe they don't tip the scales at a level to say they need to be on a bariatric surface, but the problem is they can't effectively turn. They need a bariatric bed so that they have the width to allow them to turn effectively. So consider both weight and girth, the patient's ability to be repositioned and to assist with repositioning. If you have bariatric patients, in addition to needing bariatric beds and mattresses, you need repositioning aids. And most of the major companies have very effective repositioning devices that are Gore-Tex. Many of them also have air inflation. But with these devices, literally 2 nurses can reposition a patient who's 500 pounds without endangering the patient, without endangering the nurses, and without compromising the patient's dignity by going into the room with 8 people to try to reposition that patient. So if you're taking care of bariatric patients, make sure you work with your vendor to obtain appropriate bariatric beds and mattresses, and make sure you talk to your vendor about bariatric positioning, turning and positioning devices. I think that was the main thing I wanted to talk about there. Okay. Now let's look at another way to classify your support surfaces, and we've kind of referenced this as we've gone through. I haven't talked about it in detail. You can classify devices as overlays or mattresses or beds. Now, overlays are obviously designed to go on top of the existing hospital mattress and to help compensate for the deficits in the hospital mattress. This is actually where we started out with egg crates and alternating air overlays. And they were designed to provide more conformability than the existing hospital mattress. Here's the thing about overlays. In inpatient settings, acute care, long-term acute care, long-term care, we are moving away, we've almost totally moved away from use of overlays. And that's primarily been driven by safety initiatives, because when you add an overlay to an existing hospital mattress, typically you're adding 2 to 4 inches. That can increase the patient's risk of entrapment, increase the risk of falls. In addition, the use of overlays to provide pressure redistribution adds a lot of cost to the agency's bottom line. Even though they're the least expensive device per unit, the reality is every time a patient's admitted to that bed and that patient needs pressure redistribution, you have to go get another device. So if over the course of 1 year, you had 30 patients admitted to this bed who needed pressure redistribution, and if each device cost you, we'll use a very limited fee, we'll say $30. That means that over the course of that year, you've paid $900 just to protect patients in that bed. And that's if you only have 30. Many times you have a lot more than that. You take that and you say, well, if I spend $900 in 1 year, never mind the cost associated with inventory and storage and everything. If I spend $900 in 1 year and I look at 3 years, that's $2,700. You could have bought a very, very good quality pressure redistribution mattress for that bed and eliminated all of those costs. The other reason that you want to move away from overlays is that almost always there will be a lag time between when the patient's admitted. Then somebody comes in, does the risk assessment, realizes that this patient's at risk and the patient needs an overlay. Oh, it's the end of the shift, I'll pass it on to the next shift. Next shift's very busy. Ends up it's 24 hours before that patient's placed on the overlay. In contrast, if you replace all of the mattresses in your agency with pressure redistribution mattresses, every single patient gets baseline protection, and they get it from the moment they're positioned on that mattress. From the minute you admit them to that mattress, to that bed, they're protected. But I don't want you to think that overlays have no place. What about home care? Most of the time you're not going to get a totally different mattress. You're not going to have a hospital bed in home care many times. Many times you're going to put something on the patient's existing bed. And you are dealing with one patient. So it makes good sense to use an overlay if an overlay can give you what you need. So are overlays still valid devices? Yes, you just want to look at your care setting to say, is this what we should be using in my care setting? The trend in inpatient is to go with what we call purchase replacement mattresses. So when we talk about relationship to mattress and bed, a replacement mattress does just that. You get rid of all the standard hospital mattresses that lack pressure redistribution capabilities, and you replace them with mattresses that have been designed to provide even pressure distribution, to provide conformability at the surface. So the new mattresses, the mattresses that we now have available, combine all the features of standard hospital mattresses, bacteriostatic cover that can be effectively cleaned between patients with pressure redistribution capabilities. That is the trend. Much more cost effective, elevates the level of care, eliminates gaps between when the patient's admitted to the bed and when they get the overlay that they need, eliminates the safety issues with increasing the height of the mattress. Now, one of the things you have to think about is when were those mattresses purchased and how long was the warranty? Because you definitely have to replace them before the warranty expires. Now, in some agencies, this is pretty simple because they replaced all the mattresses at once, so maybe they replaced them all in 2010. They have a 4-year warranty, so they're scheduled for replacement house-wide 2014. Great. Other agencies have replaced mattresses a certain number every year. So maybe they started out in 2000, or let's make it more recent. Let's say they started out in 2008, and they replaced 100 mattresses in 2008, 100 mattresses in 2009, 100 in 2010, and we'll give them a 4-year warranty. Okay, that means that the ones that were replaced in 2008 are due to be replaced this year, 2012. Do you know which of the mattresses were the original 100? Because you know how beds move. Patients move, beds move. It becomes a logistical nightmare. So one of your responsibilities as the wound care nurse, if you're in an inpatient setting, and if you have pressure redistribution mattresses on the beds, is to meet with purchasing, materials management, whoever is responsible, and find out when were these mattresses purchased and what's the warranty period, and make sure that you replace them before before the warranty expires. You can also get rental mattresses. Now, rental mattresses are, in general, high-level devices that provide air support, a very conformable surface. Most of them also provide microclimate control through that pump and the little perforations. You can get rental mattresses or you can get rental beds. If what you need for that patient is high-level pressure redistribution, shear and friction control, and microclimate control, by far the more cost-effective approach is to get a rental mattress. Now, of course, some hospitals have just put these high-level air support mattresses on every ICU bed. So, you want to see what you have. It may be that in all of your high-risk areas, you've already got air support, low shear, low friction, a pump-driven system that has microperforations, and your hospital might own those. Great. Again, you just need to know what you have and make sure that the surfaces you have are being used appropriately. What about rental beds? In general, if you get a rental bed, it should be because you need something more than just high-level pressure distribution, shear and friction control, and microclimate control, because you can get all of that from a rental mattress at a much lower fee. So usually when you get a rental bed, it's because you need other features as well as those three major features. Just know that when you're renting a bed, that's the highest level therapy. Now, we will talk briefly about air fluidized beds like Plenatron, Fluid Air. Some plastic surgeons like to place patients on that type of surface post-flap for a period of time so that they're literally floating. And so that, of course, is a rental bed. You can't get that feature from a mattress. You can't get an air fluidized mattress. You have to get an air fluidized bed. But in general, you can get high-level protection from a rental mattress. Now, the last way to classify support surfaces is by the support medium. What are they made of? There's actually 4, but we're going to talk about 2. There's foam, there's water, there's gel, and there's air. But the 2 most commonly used are foam and air, and those are the 2 that we're going to talk about. Now, in the past, we used a lot of foam overlays, but we've moved away from use of foam overlays because of disposal issues, fire retardancy issues, the fact that once foam is soiled, it has to be thrown away, the fact that if you cover it with a waterproof cover so that it's protected against soiling, you typically get increased problems with diaphoresis, sweating, moisture, all of that kind of stuff. But foam is extremely valuable in construction of pressure redistribution mattresses because you can combine different types of foam. You can combine very dense foam at the base that gives you long-term support. That's what's in a lot of our furniture. And then the top layer can be a very conformable foam that allows contouring so that you get more even pressure distribution. You need to be aware that there's all levels of foam. There's everything from those little egg crate kind of foam overlays that give you no significant support and very ineffective pressure redistribution, to very high-level, highly therapeutic foams like your viscoelastic foams that have memory and that contour very effectively. Goes back to whenever you're purchasing any product looking to replace mattresses agency-wide, you want to have a meeting with everybody involved in the decision and with the top vendors that you're considering, and you want to look at their data. You want to know what is used to construct that mattress. You want to know what their warranty period is. You want references. You want to be able to talk to other agencies who have used those devices. And you want to see their data. You want to see their data about interface pressures. They should have done testing to see what the interface pressures are for patients placed on this device. They always do testing, of course, with healthy volunteers, but they should have looked at healthy volunteers who are slender, who are normal weight, who are moderately overweight, who are obese. They should be able to give you information about how their product performs. See if there's anything else I want to talk about related to foam. I think that's primarily it. Okay, now come to air. We've already said your highest level devices are your air support devices. And we've talked about how extremely conformable air is as long as you have a conformable surface and as long as you maintain proper inflation. Obviously, the air has to be in the device. If it's all leaked out of the device, then it's not going to help your patient at all. And there's two mechanisms for maintaining inflation. Now, a lot of times, if you look at the third slide down, so here you see a pump. A lot of your mattresses, your rental mattresses, some of the purchase mattresses that you have in ICU will probably be pump-driven. The advantage of pump-driven devices is that you know that inflation will be maintained, and most of them have a battery backup for transport or for the possibility of power failure. But some of your devices are like this. They have no pump. They're what we call a static device. You fill it with air, and then you disconnect the pump. It's not maintained by a pump on a continual basis. If you use waffle mattresses, soft care mattresses, then you pump them up. And what you want to do here is you want to, first of all, follow the manufacturer's guidelines. If you overinflate, then you create a very stiff top layer so that the mattress, the overlay is not conformable and you don't get pressure redistribution. It's just like putting them on the underlying mattress. So do not overinflate. You want to make sure your staff knows that more is not better. If you underinflate, you don't get enough support to get the patient off the underlying mattress. So adequately and correctly inflating those devices is critical. Plus, periodically, if it's an overlay, you should be checking for bottoming out. You should be putting your hand between the mattress and the overlay to make sure that the patient is getting adequate support. You've got reactive versus dynamic. I'm just going to mention these terms because you'll hear them. Reactive surfaces means that the air shifts in relation to changes in the patient's position. And a lot of the devices that are out there now are designed to be reactive, to respond to any shift in the patient's position. So you'll have channels between air cells that allow air to shift from one cell to another. Dynamic devices are those devices like alternating air, where the pump constantly changes air from one chamber to another. The trend is to go with more reactive devices because remember, we're aiming for even pressure distribution. So if I turn to the right, then my center of gravity is shifted and you want the air to shift around me to compensate for the shift in position. So that's what they're talking about with reactive versus dynamic. We've talked briefly about your air overlays, like your vinyl air overlays. You see that on your handout, whether you're using the one on Blackboard or the hard copy. I wanted to talk about this term, low air loss. A lot of companies will say, oh, this is a low air loss mattress. This is a low air loss bed. This is a low air loss overlay. In general, the term low air loss is used to refer to an air support surface that has a fairly conformable top layer so that the patient contours to a device that includes a low shear, low friction cover, and to a device that has perforations in the surface so that when the air circulates through the mattress or through the overlay, you get air against the patient's skin to keep the skin cool and dry. So low air loss overlays, mattresses, beds typically provide high level pressure redistribution, shear and friction control, and microclimate control. They're considered to be a very high level device. I did want to just briefly differentiate between a low air loss overlay and a low air loss mattress. I want you to notice the depth of the air cells with a low air loss mattress. These are very deep air cells. So even if you have a heavy patient or a patient with contractures, they're going to be well supported by that low air loss mattress. In contrast, the low air loss overlay does give you air support, does give you shear and friction control most of the time, and does give you low volume airflow, but your air cells are going to be much thinner. Remember the height issue. So you're usually talking no more than 4 inches, frequently more like 2 inches. For a small patient who's not contracted, that low air loss overlay may give you excellent protection. But if you have a very heavy patient or a patient with contractures, they are very likely to bottom out. Back to our earlier point, you always check your overlays. And if it's not giving enough protection, you go to a mattress. One advantage of low air loss mattresses and low air loss beds, you can see that it's mounted on a standard hospital bed frame. That means that you retain the ability to do head of bed elevation, to gash the knees a little bit, all of those things which are very important when you have a patient who needs head of bed elevation because of tube feedings, because of BAP prevention protocols, whatever. And then the last thing I wanted to talk about was air fluidized therapy. That's your Clinotron, your fluid air. It's called air fluidized therapy because what you have here is literally a tank. That tank is filled with glass beads that have been coated with silicone, so they're very slippery. It's pump driven. When the pump is turned on, air is blown through all of those little glass beads. They're all put into motion. You've got your cover sheet that's extremely conformable and extremely permeable, and the patient's literally floating on that cover sheet, on this, constantly fluidized surface. So you get extremely high level pressure redistribution. You do get shear and friction control. You get very high volume airflow that will definitely keep the skin cool and dry, or at least dry. Sometimes these beds are hot because of all of the energy expended in running that pump and keeping all of those beads in motion. But it will keep the skin dry. Actually, it can be too drying. In some situations, we've had problems with dressings drying out if we didn't have them covered with like a transparent adhesive dressing. If you had a patient who was very high risk for dehydration, you think twice before you put them on an air fluidized bed. The other thing that you want to think about with air fluidized beds is that in the standard beds, you cannot elevate the head of the bed very effectively. They give you wedges, but patients tend to slide down off the wedges. So not a very good choice for patients who are on tube feeds, not a good choice for patients who have pneumonia or who are on BAP prevention protocols. Now, they do make a hybrid of this device where you can get the head is low air loss, and then the trunk area is air fluidized. That's called right height, and some of you may be familiar with that. But basically, you are not going to use this as a standard surface. It will be very much a special use surface. Like I mentioned, sometimes plastic surgeons like to put their patients on this post-flat. There's very limited data suggesting that if you have patients with advanced stage 3, 4 wounds that are not healing well, another high-level surface like low air loss, they might do better on air fluidized. We need a lot more data. Right now, I want you to focus primarily on thinking about which patients can be effectively managed on your mid-level devices that give you good quality pressure redistribution, may give you shear and friction control. Which patients should be placed on a high-level device, which is going to be an air support, typically an air support mattress, for some patients possibly an overlay, but for most patients a mattress, with shear and friction control surface and with airflow. I want you to think of your air fluidized as very much a specialty product that would be used in very limited situations. These are expensive, they're heavy, they're hot, they can be disorienting. They can also be highly protective of the tissue integrity and may promote healing. But you don't want to think of this as first-line therapy. You want to think of it very selectively. Okay, we're almost through. I wanted to mention chair cushions. Here's the things you want to think about. Any patient who is at risk and who gets out of bed should have a chair cushion. Whether they're wheelchair bound or they're just getting up to the bedside chair, they should not be in the chair without a cushion. What about donuts? Absolutely not. People still sometimes want to put people on donuts because it looks to them as if they're getting great pressure relief. They're like, well, look, I've totally offloaded the ischial tuberosities or the sacrococcygeal area. You have offloaded it, but you've compressed all the tissue around that area. If you compress all the tissue around the area, you get peak pressures all the way around. Blood gets shunted away from that circular area. Now you've compromised blood flow into the area and you've compromised venous return. So you want everybody to know we never, ever, ever use donut-type devices. If you're looking at chair cushions for people who are just getting out of bed to the chair, you know, there's a wide variety available. You can use air cushions, you can use foam cushions, you can use gel cushions. If you are working with patients who are wheelchair bound and who are going to be using this cushion as a primary element of their pressure ulcer prevention program, you want to call around and find which agency in your area has a seating clinic, SEATING clinic. They will have physical therapists and other people who know how to evaluate that patient and to make the best choice for a wheelchair cushion. A cushion that matches the wheelchair, matches the patient's needs. Is impacted by their trunk stability. Many factors impact on the proper selection of a wheelchair cushion. I don't know the things I need to know to do that. I'm always going to refer that patient or at least get assistance. And then the last thing I wanted to go over is your role in management and appropriate utilization of support surfaces in your agency. This is a really important part of your role. A lot of wound care nurses are refer to themselves as the bed police. For most people, it's not their favorite part of the role, but it is very important in providing patients with the protection they need. It's also very important in providing cost-effective care, and it can be a very rapid way to prove your worth to the agency and to justify your role. So first of all, you want to be involved in product selection. You want to be working with other people involved in product selection and meeting with the vendors and asking the critical questions and reviewing their data and checking references. You want to know exactly what their warranty program involves. You also want to know what level of support is available from that company. If you're having problems, is somebody going to be out there to help you? Or are you just going to be shunted from one person to another? So you really want to find out about level of support, data available, what studies have been done on this product. They should be able to give you studies, give you references. A very important decision or a very important responsibility is development or updates on a decision tree or algorithm for bed selection. Now, first of all, you want to limit how many products people are having to choose between. For those of you in an acute care setting where this is usually the biggest issue, hopefully you have pressure redistribution mattresses on all of your beds so that every patient gets basic pressure redistribution. Then what else do you need? Well, you do need a rental mattress or rental bed that provides high-level therapy, optimal pressure redistribution, shear friction control, microclimate control. You probably need a device that provides continuous lateral rotation therapy for your patients with pulmonary issues. You definitely need a bariatric surface and bed if you have bariatric patients. So you want to keep it pretty simple. If you have patients own a good quality pressure redistribution device mattress, then basically you've got to give people guidance as to who goes on a bariatric surface, and that comes down to weight and girth. Who goes on continuous lateral rotation therapy? That's all pulmonary issues. And who goes on the high-level rental device for high-level pressure redistribution, microclimate control, etc. You can keep it very simple. And remember, everybody gets heel elevation. You're also going to need to provide backup to your staff because there's going to be some patients that they're like, well, I'm not really sure, you know, and looking at the decision tree, it looks like I should just leave her on the pressure redistribution mattress we have, but I'm worried about her because she just seems so high risk to me. Can you come look at her and help me decide if I should move her up? And then finally, you want to develop a system so that you make sure that any replacement mattresses get replaced before the warranty expires. That's a clinical issue and a very important clinical patient safety issue. You also want to set up a system for making sure that expensive rental surfaces are discontinued when they're no longer needed. So you want to use them when they're needed and you want them out of there when the patient no longer needs that surface. Okay, I think that's what we wanted to include in this section, so I'm going to stop the tape. Our next lecture will be on wound healing. So when you get ready to go to that one, you'll again. Thank you.